This is Waves, a podcast from APTA Michigan. I'm Andy Wicks. Physical therapists and physical therapist assistants work in all kinds of settings, something that isn't always acknowledged or appreciated by the public, and even by the profession at times. My students frequently tell me how surprised they are to learn about the wide variety of places they can work. In case you haven't already, you can add prisons to that list. My guest today is Dr. Tiffany Wolf, a woman who has worked just about everywhere. We started out talking about her experiences working in the correctional system, but as many good conversations tend to do, it went a bit off the rails from there. I hope you enjoy.
Hi all, my name's Tiffany Wolf. I am a physical therapist in the Denver metro area. I am a Colorado native. I've been practicing for 19 years in May, and I have been in just about every setting that you can imagine. My passion is more in the outpatient setting, and typically more with the patient that has failed PT, the challenging cases.
Ooh.
Those tend to find me. But I've done a lot of other
Okay.
interesting things in the years.
Okay, well, we can talk about that too. And the reason why you and I are talking right now is because I reached out to ask if anybody knew anybody who worked as a physical therapist in the correctional facility system or worked with inmates. And Dr. Rebecca Griffith, the EDDPT, who also knows everybody, was like, oh, hey, guess what? I know somebody. And it happened to be Dr. Tiffany Wolf. So Tiffany, I guess easiest question is, how did you get in that setting?
So interesting. My previous clinic that I worked in, we didn't do just outpatient ortho. We had other contracts outside, including industrial health at some of the factories. And my boss's contacts knew that she did factory setting. And so they reached out to her to help get PT on site at the correctional facilities that were literally just across the railroad tracks from the factories we worked in.
Convenient.
It happened just kind of organically that way, that people knew people, and she got us signed on to go on site at both the men's and women's facilities to work with the offenders.
Wow. There's a part of me that wants to ask, like, what was the scariest thing you ever saw? But I guess how different was it from just working in the clinic?
In all honesty, it was the most different because I didn't have access to all of the equipment or toys that I would like to have. We started there just before COVID started. And so that put a giant wrench in what our plan was to get like a set space over in the rec room athletic area they had. But then COVID hit and none of that was happening. Yeah. So we had a physician's office treatment room with a physician's type examination table. And it was creative therapy. I could bring in racquetballs, exercise bands, gait belt, but anything I carried with me had to leave with me. And it was a lot of creative home exercise programs, trying to find things that the offenders had that could second as a stretching tool, as a resistance band. So it became, and they're creative regardless. So they easily helped us find ways to make it happen.
That's fascinating, because I think in a lot of ways, we as therapists, we love our toys.
Oh yeah.
Like, we love the shiny new toy and things like that. But it really puts your clinical decision-making skills to the test when suddenly you're like, okay, you don't have any of those toys. Correct. And your patient doesn't have access to any of those things. And now you have to make a home exercise program that works. That's so interesting.
Yeah.
Oh my
goodness.
goodness.
You definitely had to learn your patient outside of just the patient population. You had to learn your patient and figure out what they were going to be willing to do. And you had to win them over to buy into therapy. Like, we have to get patients to buy in every day, but this was kind of like next level because they've already been failed by medical providers, other PTs, because unfortunately they're kind of lower on the totem pole. And so things get pushed back like, oh, that's not a priority. That's not a priority. So when they finally get to see someone and then they see us consistently for a few weeks, get them to get the buy-in and we make a big difference.
That's so fascinating, because I was just going to say, like, building that patient rapport is crucial no matter what you're setting. But
Right.
what a what a new wrinkle
Yeah,
that
really.
you have, because on the one hand you have a patient population that is a captive audience. Maybe that's a bad pun.
Right.
But yeah, like to see that maybe they've just been disappointed left and right, and to recognize that how do I get to
Right.
show you that yes, they do have your best interest at heart, and I am going to be here for you.
Right.
God, that's got to be tough.
Yeah. So it's
So
interesting because, again, we're a new provider on site to see them. And so some of them want to see what they can get away with from you. Like,
Sure.
if I ask
Sure.
this girl for this, will she finally get it for me?
Mhm.
Well, luckily, I've been practicing long enough that, you can kind of tell
Yeah.
when someone's
Yeah.
trying to pull your chain.
So a lot of the people that I think listen to this podcast are students, because I
Oh,
teach
yeah.
in a physical therapy program. So I have some of my students, I think they have to listen to it for their grade, which I'm
Well,
not going to
welcome,
tell them they don't. Yeah. So, but we talk a lot about things like doing a needs assessment for your patient and making, and things like health literacy and social
Mhm.
determinants of healthcare and things like that. So what were some of the steps that you took to reach that population who have very different needs than, say, your typical outpatient clinic?
So I would fall back on our skill set as PTs. The only things we need as PTs are our brain, our hands, and our patient. Bottom line, that's all we need as a PT. And we need our
Okay.
patients to give us their subjective. If you genuinely sit down and listen to the patient in any setting, but especially with a population that feels like they really haven't been heard, like, you get the buy-in right away. You listen, and
Yeah.
if you're listening, they're going to tell you exactly what's going on. They're going to point you right down the path of, this is what causes my pain, this is what makes it better, and so on.
Yeah. Yeah.
So those few things, laying your hands on people as PTs is such a skill set that we have and we utilize. And that alone, just the laying of hands on patients, whether or not we're actually doing any real adjustments,
Yeah.
it's just assessment, makes the world of difference.
Mm-hmm. Mm-hmm.
So, and that's
it's
really
a
where
human
you can
communication skill.
get, it is.
It's a human communication skill. Yeah. We talk about that active listening, which is a hard skill, I think, especially for students. Yes, for students, absolutely.
Right.
Even new clinicians, and I think clinicians who are maybe in an uncomfortable setting because you're trying to gather in as much information as possible. You also have your computer there, so you're trying to document and be efficient with your time,
Right.
and you're getting distracted, but yeah, not even just sitting down to see the patient and really hear, because that, yeah, like you said, like that piece of it that's an intervention in and of itself. I think.
Absolutely. Absolutely.
Just to listen and tell your story, and then we'll figure out the rest of the stuff.
Absolutely. And I think part of that skill set has led me to working with a more challenging population even in outpatient ortho, because patients see me once they've already failed PT in other settings. And they're like, what are you going to do for me that that other PT wasn't able to do?
Yeah. They're already coming up with a wall.
Oh, absolutely.
Yeah.
Yeah.
Okay. So we'll get to that in a second. So how long did you work in the correctional?
Would have been about
program?
4 years altogether that I was there. And things got better as we all kind of came out of the COVID fog, and we were able to have a little bit more freedom of location that we could see the offenders, things that we were allowed to bring in, things like that. And the amount of time that we were allowed to spend with patients. Could we spend a full hour with them? Did the correctional facilities have enough staff to allow us as outside providers to be able to come on site? So things like that slowly got better as we all kind of came out of the COVID fog.
Yeah. I would imagine logistically that's a lot of moving parts that you have to coordinate.
Absolutely. Yeah. And getting authorization for the patients was a whole other beast, because it's state government. So it's another VA, it's another Medicaid process of getting approval and visits and such. So those were hoops that you had to jump through as well.
So eventually you got to these hour-long appointments. How often would you see them?
Typically, you'd only see them once a week. And then because timing-wise and staffing-wise, we didn't have enough time on site or space on site that we could see them multiple times a week. And so if we could get them in once a week for like 6 visits, that was kind of average, then we'd be in a really good place. And so it was really hammering home programs. Like, what are you going to do to get yourself better? I'm only this much of the puzzle.
Yeah.
You know,
That's a great
point
point.
you in the right direction, but then you have to take the wheel.
Interesting. You know, that's something that maybe we don't emphasize enough, that yes, I will see you for these 6 visits, hopefully.
Right.
But that is 6 total hours over, you know, the course of 6 weeks. So
right.
It's a lot of other time.
Mm-hmm.
Interesting. Okay. So we also have this debate among my students sometimes. How many exercises is the best number of exercises for a home exercise program?
I'll preface it with, it depends on the patient.
Okay, fair.
My absolute max that I'll give someone is 6 exercises. That's my absolute max. But that's my person that's like training for a race, has to get better by this time frame. But if it's my patient that has failed PT, is giving me the, what are you going to do for me? That she didn't do before, you know, they're maybe 2 exercises at most.
Okay. There you go.
I tend to have patients try to stack one of their exercises with like brushing their teeth or going to the bathroom. We're habit stacking to make it not this extra chunk of time they have to carve out of their day.
Yeah. Commercials. See, this is the problem with DVR and the streaming thing, is we can always skip through the commercials, and that used to be prime home exercise program time.
Honestly, so true. Every time the commercial comes on, go take a lap around your kitchen.
Yeah. You got 2.5 minutes. Let's go. Come on, get those exercises done. And then you're going to be tired. You can sit down and watch your show.
Absolutely.
Okay.
Yep.
So let's talk about the failed patient now. I think a lot of us every therapist likes to think they're the best. I mean,
of course.
Because we are. So, but that is just, objectively not true.
Right.
And how did you get into that patient population of the failed patient? I think it's an interesting population that we don't talk about, but we all know who
we all know those patients.
Everyone's like, oh yeah, I know exactly. Yeah. So I know you mentioned like chronic pain.
Yeah.
In your little survey thing. So like that's, I think for a lot of people, they hear chronic pain, they go,
like, oh.
Yeah. Oh no.
Yeah.
Okay.
Like, chronic pain. Oh. Again, what am I going to do for this patient?
Yeah. But I also see that you have your lymphedema certification.
Correct.
And you work, looks like, with the oncology sphere. So talk a little bit more about all that.
Yeah. So I'm not exactly sure how it happened that patients that had struggled or failed PT in the past, they just kind of started gravitating towards me. My colleagues at previous clinics would be like, oh, this is a tough one, Tiff. Why don't you see her and see if there's something different you can figure out? And then we would make a great relationship, and it was, it's chronic pain. So these are the patients that tend to stick with me, and it becomes a maintenance type. Come see me once a month, every 3 months, when you feel a migraine coming, things like that. But it was those type of just kind of organically found its way to me through referrals. And then from friends and family type referrals, we're like, hey, she did really well with me. I bet you could go and see her for whatever. Yeah. I've worked a lot with Ehlers-Danlos patients, which it's interesting because not a lot of people, one, know what it is, or two, know what to do with that patient when they walk through
What to do about
door.
it, exactly. Yeah. If they do know what it is, they don't know what to do about it. It's interesting you mentioned that.
Yeah.
I literally just published an episode yesterday or 2 days ago with a guy who he and his wife are co-owners of private practice in Evansville, Indiana, and they are a center of excellence through the Ehlers-Danlos Society.
Nice.
So they do a lot of work with that hypermobility population.
Yes.
And I was like, I've never known of anyone to kind of focus on that. And now I met a second person. So that's really cool.
Yeah. And it's really interesting when those patients come to you. Some of them don't even know that that's what their hypermobility is, but that's exactly how they present. Or you get the patient that has had the diagnosis for decades, and every time they go see a new provider, that provider has no idea what it is. And so they have to step back and tell their whole story.
How exhausting.
Yes.
How exhausting.
It's very. So being able to already understand the diagnosis and the disease process a little bit, and having had some success with those patients, has made, again, patients buy into working with me in that area. So
that's fantastic. My old boss, my first boss and my first job out of PT school, got her CLT. And I remember when she told me the amount of work she had to do to get her CLT. I was
no
like,
joke.
Really? It was one of these things. And Tanya, if you ever listen to this episode, forgive me if I get the details wrong, but it was one of these where it was something she was interested in. And for whatever reason or another, the timing of the continuing ed course didn't work out, or the funding wasn't there, blah, blah, blah. And then she got another email from them that like, hey, we've extended the deadline and lowered the price. And suddenly she's like, oh, I could actually make this work. So she signed up for it. And then she got all like the pre-course material.
Right.
It was like 30 hours of stuff before the class even started. And it was a 9-day course.
Yep.
Yeah. But she came back and I remember like texting her during it. I'm like, how are you doing? She's like, oh, exhausted, but like at the same time, very energized. And that's actually what she does full time now. She works at a local cancer center as one of their lymphedema therapists.
Excellent.
And she just loves it. She's living her best life now, but
fabulous.
when she would show me the things that she could do.
Yeah.
The clinic where we worked was a neuro rehab clinic. So we had a lot of TBI, a lot of polytrauma. So a lot of, especially lower extremity lymphedema, stuff like that with immobility, blah, blah, blah. And when she would show me what she could do with that stuff, it was like magic.
Yeah.
It was crazy.
It's pretty cool. And it's fun because you can see improvement pretty quickly when you do it right. And that really makes patients see, oh, hey, okay, we're going to get better. This isn't the end of the road. So,
Yep. Yeah. It's like when you do that Epley maneuver and all of a sudden the patient's like, I'm not dizzy anymore. You're like, I'm the best therapist.
Absolutely.
This stuff really works.
Yeah.
Okay.
Yeah.
So you've worked in the prison population. You've worked in the chronic pain population. And it looks like you've worked in the oncology population as well as just, let's see, I'm looking at acute care, rehab, school-based health. Is there anything you haven't done? Pediatrics?
I've done a little bit of peds.
Of course.
And I'll tell you this. The reason I really have done a lot of everything is because my first 6-7 years out of PT school, I lived in rural Nevada. And so you absolutely have to be a general practitioner when you live in the middle of nowhere because you're it and you got to figure it out.
Okay. Yeah.
So.
Okay. So let's dive down this road a little bit. The generalist versus the specialist.
Yeah.
Okay.
Yeah.
Every program in the country, every DPT program will tell you that they prepare their students to be generalists. However, the faculty of most of those programs are specialists.
Yep.
And me included. I'm guilty of this as well. And I've interviewed a few people who work kind of in that rural setting.
Yep.
Who absolutely have to be literally the Jack and Jill of all trades to be like, I am the only person here to help out. And I think this, to me, is very, very interesting because yes, I feel like, okay, I passed the NPTE, so I do have a basic, basis of musculoskeletal knowledge, and I do remember my pediatric reflexes in terms of when they emerged and when they are integrated, blah, blah, blah. But I would not be my first choice for treating a lot of those populations. This is not where I've spent my time.
Right.
But for the people who are in that rural area, become almost primary care providers.
Right.
And I think that's fascinating because to me, I was telling some of my students this, I feel like that's the direction that physical therapy is going to go.
Agreed.
In the future. Like that's the space we have to move, is to move more into that primary care model. And I think the rural setting is maybe like the best or the most fertile soil for that.
Right. I would agree with that. And of course, when I graduated PT school, I heard the same thing. It was, you have graduated as a generalist. Now go and live your best life. And I think I was probably my only classmate that went and actually worked as a generalist. Everyone else started branching off into peds, neuro, ortho. But I'll tell you, I think those first few years of working in a rural setting, having to treat all of the things made me a better therapist in the long run.
Oh, yeah. I would imagine so.
Because it boils it down to, what are we doing as PTs? We're trying to improve people's function, period, right? So we want to get people back to what it is they want to do. Is it to get back to work? Is it to be able to play with their grandkids? Is it whatever the task, the function is, bring it back. Do we need to get the little ones to be able to roll over or hold their head up? Do we need to get someone to be able to roll in bed so they can go from sit to stand, And then you just boil it down to that, and then use the skills you have, and then start reaching out to contacts, doing research, see what's out there. Trial and error. I mean.
Yeah. So I would imagine in rural Nevada, you probably didn't have an extensive interdisciplinary network in terms of people you could reach out to, but I hope that you probably found, I'm assuming there were some people that you could at least reach out to of like, hey, I'm good at what I do, but I've never seen this before.
Correct.
Seen when I've been out there. Yeah.
Yeah.
And I think that's a great lesson about just integrating into that interdisciplinary
definitely
process that, yes, we're good at a lot of things, but we have a scope of practice with limits.
Correct.
And we definitely need to know when to reach outside of that.
Absolutely.
To help us out.
And I think one of the other perks of a rural setting, close-knit community type thing was that, yes, we all have relationships with physicians or providers, but I think the rural setting is, these providers even more than that, and they know you. Your kids go to school together.
Small town living.
Like, you have spouses that work together. It's much smaller community. So it was a great experience.
I can imagine so.
Yeah.
Man. Okay. All right. So acute care, rehab, school-based, home health, outpatient, and then you're outpatient ortho right now?
Correct.
Okay.
Yep.
With all those challenging failed patients?
With all of my, yep.
All of them. So when you get your, I'll just say like your standard knee replacement patient, do you get bored?
I kind of do. But sometimes if my patient load is stacked with really tough patients, I love when a total joint shows up on my schedule.
There you go. You're like, okay.
I'll take that breather that takes not as much brain power as the others. But
nice.
Once upon a time, I saw total knees all week long.
No, someone's got to.
Yeah,
There's a lot of total knees out there.
Yeah.
Someone's got to.
And, you get better as a PT as the longer you work, and you find your niche and the skills you like and the things you want to improve upon, and kind of directs where you go career-wise.
In addition to your varied career, looks like you've had a lot of students. You've been a clinical instructor.
I have. I love having students.
Good.
Yes.
Good. So what, in your opinion, what makes a good, how do I want to phrase this? I'm trying to be delicate about it.
Sure.
How would a student best prepare themselves for a clinical rotation with you?
Let's see. How would I tell them that?
What would you say? If the student reached out to you and said, hey, Dr. Wolf, I'm going to be in your clinic.
Right.
And especially, I'm going to throw a wrinkle in there.
Okay.
If they told you, I outpatient ortho just isn't my thing, but I'm going to try my best,
Right.
Okay.
Yeah.
What do you say to that student?
So that student, I'm going to tell them, come with open eyes, open mind, be prepared in the material. You're coming to an orthopedic clinic. So go back and review your MSK, and then, communicate what type of learning style do you have? Do you prefer to watch once and then try? Do you want to jump right in? How do you want to receive your feedback? Having those conversations with students, so you kind of pave the way for what works best for them, the way they already know. But then I tend to be a gloves off type of instructor where I'm like, here, this is what we're going to do.
Yep.
That's it. And, if they start to feel like they're failing, I'll jump in, give them some clues. But in all honesty, as PTs, the more you get your hands on patients, the better, period. Whether or not your hands are in the right spot, doesn't matter. Like, try and find some PSIS. Well, no.
So we all make those mistakes.
Oh, absolutely.
It's funny when you talked about like getting our hands on people.
Yeah.
Because I remember this as a student. I see it in my students. Like, you go into physical therapy, and most students coming into physical therapy have their background in that outpatient ortho world.
Typically.
Either like they were an athlete and injured and went through PT.
Yeah.
They've worked as an aide in a clinic like that.
Right.
So they know there's a lot of hands-on. But you get into the safe space of class and lab, and all you're doing is ever working on your partner.
Right.
And suddenly when you're like, here is a real patient, you're just like,
what do I
don't know
do?
what to do.
Totally.
I'm terrified. But that's again part of the learning process.
It is.
So, okay.
Yeah.
So I have a couple questions, but I want to make sure I'm asking good questions here. So here's your chance to brag a little bit.
Oh.
What makes your clinical experiences with your students so good? What makes them the best?
I think part of what makes them go well is that I do give them a lot of independence and that I try to give them a lot of support when and where they need it. I'm not trying to dictate how they're treating their patients. I'm trying to brainstorm with them. Like, okay, let's sit down and go through this subjective. What is this subjective telling you? Okay. Do they fit in that box? Do they fit in the low back pain box? No?
Yeah.
Okay. What else do you want to know? What do you need to objectively measure to point you down the next road in your examination and evaluation? And then just kind of working through it together and then watching them build their skill set and then building that confidence, which it absolutely comes with repetition and time in the clinic. So
it's like these students, they have the pieces of knowledge.
Absolutely.
They're in there, but they haven't connected them.
Correct.
They haven't made the clinical, those little clinical pearls of wisdom.
Yes.
So that's our job, is to help them draw the line from point A to point B so they can recognize it. Oh, now I get it.
I found working with some students really benefited when we would do random case studies where I would present a patient to them as like a homework assignment. Like, here's this patient with these complaints, this medical history. What do you want to know? And then once you answer those questions, what do you think your plan of care is going to be? And then we can review it and be like, well, no, that person actually has already had a stroke, so we need to change that.
Yep.
And that went over really well with some students.
Yeah.
So.
And I think that's the nice thing about that kind of a situation with that case study thing, is that it's a safe space to fail.
Absolutely.
So like if they make a mistake, you're like, okay, well, no harm, no foul in this one. But I think it also could set them up for a way of, in the clinic, when you make that mistake or when your plan fails, which will, to instead of just crumble, to just pivot and adapt,
adjust your sails.
And that's, exactly. And I think that's a hard skill.
Yes.
To recognize, because how many of our students, it's like they want to get it right the first time. And I get it.
Yes.
Like, they're driven by success. These are smart students. They worked very hard to get into these programs, but PT is a messy, dirty, nasty place sometimes. And it just doesn't fit those.
It's not streamlined, bumpy, hills and valleys. Yeah.
Okay. So Tiffany, on this podcast, we encourage the standing on of soapboxes.
Ooh.
And the opportunity to spout whatever topic is near and dear to your heart. So if you have a soapbox or four,
the
floor is yours.
Oh, I've got a soapbox for you.
Okay, let's hear it.
I think any medical provider would really agree with me on this, especially PTs.
Okay.
We need to help our patients become better advocates for themselves. In the day and age, the way our healthcare system is set up right now, if the patient is not being an advocate for themselves, they will get passed over. And I see it so often. And that by the time a patient has made their way to me, they've already been to a PCP, a specialist, another specialist, had injections, and then they come to PT. And in all of that, they have not had any improvement in their symptoms. But because that's what providers have told them, that's what they needed, that's what they did, instead of questioning the system. Like, do I really need that? Why do I need that? What are my other options? Like, hey, I had blood drawn on Friday. Where are my results? It's been 3 days. It doesn't take that long to get my blood results back. I had an x-ray. That report should be back in my chart the next day. Like, there is no reason that patients need to wait all of this time. Like, be an advocate for yourself. As a patient, stand up for yourself. You know your body better than anybody else. Absolutely. 100%. If you feel like something is wrong, it's wrong. Feel like something's not working? It's not working. Yep. That's my soapbox.
Okay. I like it. I like it. It's great. I think you're right. And this speaks, I think, to like the topic of healthcare literacy to a degree, but it's like, for a lot of people in healthcare, they are a passive consumer. They are told what to do. It's not necessarily a conversation. It is a dictation,
Correct.
if you will. And that's hard for some people to switch that paradigm
Correct.
to more of a conversation, to more of a
Yes.
a negotiation almost.
Absolutely.
Because yes, there are times when your healthcare provider has information that you don't and perspectives that you don't. But at the same time, like you said, it's your body, it's your healthcare.
Yep. You are a consumer in your
You are a
healthcare.
consumer, exactly.
If you want a second opinion for absolutely anything, you are entitled to a second opinion. If you don't like what I have to say as your PT, I am not offended in the least if you want to go see someone else. And if you work with any provider that is offended because you want a second opinion, that is your indication to go find that second opinion.
Yeah, exactly. That is a fragile ego.
Yeah.
Oh my gosh. My God. So what do you tell the new grad who, when they would look at your resume and be like, wow, you have done a little bit of everything? What would you tell? Would you tell them to follow that path? Would you tell them to specialize? Would you tell them to?
I would tell them to follow their passion. If they're on the fence, going the route of a generalist, do it, hands down. Go see all of the things. Treat all of the people. And then in a year or two, you'll have a better idea of what you actually want to spend your days with. You know?
That's true. That's true.
I don't want to be in acute care treating wound care. That's not where I want to be. So I spend my time in the outpatient setting.
Yeah. I tell my students sometimes I'll ask them, especially as they kind of progress through the program, like, do you have a sense of where you want to be? And I think those students who don't have an idea, they get nervous, like they feel like they should.
Right.
But I'm telling you can go anywhere. And it's almost like,
anywhere.
well, are there things you don't want to do? Well, great. Then that'll help.
Yep,
then you know to avoid those kinds of jobs if you think you're going to hate it. So yeah, I like that. Very cool.
Yes.
All right. Well, Tiffany, this has been great. Thank you so much for sharing your wisdom with us. This is
glad to be here.
Yeah, it's a conversation went in directions I couldn't have predicted, but I love it. Absolutely love it. How can people find you?
I'm on Instagram at Dr. Tiff PT. My email is tiffany.wolf@thresholdpt.com.
Okay.
And you can check me on the thresholdpt.com website. You'll see my whole bio there. That's my clinic that I'm at. So,
all right, cool. We'll link to all those things in the show notes. So if you happen to be in the Denver area and you're looking for if you're a failed patient, I'm sorry,
come find me.
Find Tiff, and then she'll make you all better. All right. Well, thank you so much.
Thank you. It was great.
Dr. Tiffany Wolf is a physical therapist in Denver. She's worked just about everywhere and seen just about everything, and she's just getting started. Links to the important talking points can be found in the show notes, along with information on getting PDR credit toward license renewal just for listening to this very podcast. Offer good only if you're a PT or PTA in Michigan. Waves is a production of APTA Michigan. It is hosted by me, Andy Wicks. This episode was edited by Joey Lapidi. We can be found online at www.aptami.org or on the socials at APTAMI Subscribe to us wherever you get your favorite streaming media. I mean, you're listening to us right now, so you found us somehow. Thank you for listening, and may your documentation always be done on time.